This topic is gestational trophoblastic disease, or GTD. Pathophysiology, gestational trophoblastic disease, or GTD. These are rare tumors arising from placental trophoblasts. Those are the cells that create the outer layer of the embryo and placenta. With GTD, there is no viable fetus. It is considered a pregnancy-related cancer. It is an abnormally fertilized egg with an irregular combination of chromosomes, resulting in pathologic proliferation of trophoblasts. All of these produce HCG, human chorionic gonadotropin, which is a hormone that the placenta creates during pregnancy. The image shows a molar pregnancy, a type of GTD. A complete mole has no fetal material, and this can happen in two different ways. First, the sperm can duplicate itself. The ovum doesn't have any genetic information or has inactive maternal chromosomes, as seen in the top row of the image. This results in 46 chromosomes that are all paternal, or from the father. Another way this can happen is when two sperm fertilize that ovum with no maternal chromosomes. This is pictured in the middle row of the image. A complete mole has no amniotic fluid or membranes, no placenta, and no fetus. A partial mole has some fetal material. It happens when a normal ovum is fertilized by two sperm, seen in the bottom row of the image. These may contain an amniotic sac and fetal material, but congenital anomalies and growth restriction are usually present. Different types of GTD: molar pregnancy or hydatidiform mole. We'll talk more about this in a minute. Invasive mole, when the mole grows into the wall of the uterus, and this is cancerous, but does not normally metastasize outside of the uterus. Choriocarcinoma. This is malignant and can metastasize to other tissues and organs of the body, most commonly to the lungs, but it can spread to the liver and brain. Hydatidiform mole or molar pregnancy. A molar pregnancy or hydatidiform mole is a type of GTD that results from abnormal fertilization. It causes rapidly growing trophoblastic tissue that is initially benign but may lead to gestational trophoblastic neoplasia, or GTN, like an invasive mole or choriocarcinoma. This rapidly growing trophoblastic tissue forms an abnormal placenta. It ends up looking like a cluster of grapes that are fluid-filled. You can see this in the image here. Remember, we spoke about this earlier. There are partial moles, which contain some fetal material and an amniotic sac, and complete moles, which contain no fetal material. No amniotic fluid or membranes, no placenta, and no fetus. Either way, these pregnancies are not viable. Clinical features: vaginal bleeding that starts early in the pregnancy, as early as 4 weeks gestation, all the way up to the second trimester. This is from the detachment of the chorionic villi from the uterine wall. Uterine enlargement that is greater than gestational age, meaning that the uterus is measuring for a much larger gestational period. You can see in the image the fundal height we expect to assess for the corresponding gestational age. With a molar pregnancy, the fundal height may be measuring 28 weeks, while the actual gestational age is only 20 weeks. This enlargement is due to the trophoblastic tissue growing and quickly proliferating and clotted blood. But for some clients, the uterus measures as a smaller gestational age. Preeclampsia that develops early in the pregnancy, before 20 to 24 weeks gestation. The client will have increased blood pressure and protein in the urine. Normally, preeclampsia doesn't develop until after 24 weeks gestation. Hyperthyroidism, related to the excessive stimulation of the thyroid gland from HCG. the client will show signs of hyperthyroidism, skin that is warm and a rapid heart rate. Hyperemesis gravidarum, with nausea and vomiting that is severe from the elevated HCG levels. Absent fetal heart sounds, even though there are other clinical features of pregnancy. An abnormally increased HCG from the quick proliferation of the trophoblastic tissue. Complications: hyperthyroidism due to the overstimulation of the thyroid gland from HCG, hemorrhage, which may lead to anemia, disseminated intravascular coagulation, or DIC, which starts with numerous clots forming throughout the body, and then the body has no more clotting factor and platelets available, and that results in uncontrolled bleeding. Ovarian cysts from the elevated levels of HCG, and these may become very large, so large that they impede upon the uterus. Trophoblastic embolization to the lungs. This happens when the placental trophoblastic cells are released into the mother's bloodstream, and then they are carried to the lungs. This is an emergency and can happen after a client has had a procedure to remove the molar pregnancy. This is more common when the client has a very large uterus. Management: dilation and suction curettage, as seen in the image, where the cervix is dilated and a device is inserted to suction the molar pregnancy. This is done to completely remove all of the molar pregnancy and all of the pieces of the placenta. Because there is a risk for malignancy, some clients may also require treatment with chemotherapy. Nursing interventions: continued monitoring of HCG levels for up to 6 months to monitor for any trophoblastic tissue that remains in the body. That tissue could potentially become malignant. We would expect these levels to decrease, but if trophoblastic tissue remains, that level may increase. The client should avoid pregnancy during this time because the rise in HCG of a new pregnancy may impede the monitoring of HCG levels from the molar pregnancy. We will encourage them to use a reliable method of contraception. We also want to address any feelings of grief the client may have. Encourage the client to express their feelings, and we can offer resources for coping with a pregnancy loss. Any subsequent pregnancies will be closely monitored with pelvic ultrasound due to a higher risk of another molar pregnancy developing.